We're here today to talk about Medicaid and women's health. And I know there's quite a lot of people that are watching, and people have various sort of knowledge about what Medicaid is. So just really briefly, Medicaid is the joint and state federal program that provides medical coverage to eligible persons. And the amount that is paid for by each level of government, the federal government and the state government, is determined by the state's FMAP. That's an important term. FMAP stands for Federal Medical Assistant Percentage. And this FMAP is computed, it's a formula that takes into account the average per capita income of each state relative to the national average. Now, by federal law, the state's FMAP cannot be less than 50%. And for today's purposes, let's just say that the Texas FMAP is roughly 60-40, which means the federal government pays approximately 60% and the state pays approximately 40% to fund the Medicaid program. However, this does not include the recent COVID FMAP bump that all states received. That was an additional 6.2% bump in light of the national pandemic. And that FMAP bump is still in place and will continue theoretically until the end of the pandemic, although we're not entirely sure when that will occur. But I will say, thanks to this FMAP bump, going into this legislative cycle, we're actually experiencing zero Medicaid shortfall, which is pretty incredible because we were anticipating about a $2.5 billion budget shortfall for this next budget cycle. So it was pretty good news to hear that we weren't going to actually have a Medicaid shortfall, at least for right now. Now, we talked about Medicaid being who's eligible for Medicaid, and there's a lot of confusion about that. It's not just enough to be poor in Texas to be eligible for Medicaid. You have to be very poor. Also, you have to be either a pregnant woman, responsible for a child 18 years or younger, be blind, or have a disability or a family member in your household with a disability, or be 65 years or older. So it's not just enough to be poor in the state of Texas to qualify for Medicaid. So back in 2009, when the Affordable Care Act passed, the states were directed to expand Medicaid to serve populations like the working poor. And the states were given a very favorable FMAP to do so. Initially, that FMAP was 100%. Which means the federal government was going to pay for 100% of the costs. And then that would gradually decrease to 90%, which is where it is now. Then, of course, the United States Supreme Court ruled that states could not be forced and did not have to expand Medicaid. And Texas was one of the 12 states that decided not to do so. So in Texas, this leaves the working poor essentially ineligible for Medicaid. And that is the group that we commonly call the expansion population. And in Texas, that expansion population is right around 1 million people. And it's probably even greater given the pandemic and all the job losses that we saw subsequent to the pandemic. Now, just like this session, every legislative session for the past 5 sessions, there has been a push from different directions to expand Medicaid. And so far, this policy has really not moved forward in any meaningful way in the Texas legislature. But we may have a chance this session because we have seen a few Republicans in the House openly support Medicaid expansion. One example of that is Republican State Representative Lyle Larson. He's even filed legislation that would actually put Medicaid expansion on the ballot, which I think is a very interesting and very hopeful development. But why hasn't Medicaid been expanded in Texas when so many other states are doing it? The answer, of course, is politics. As I mentioned, Medicaid expansion was a requirement in the Affordable Care Act. And Republicans and Democrats have essentially drawn a line in the sand when it comes to the Affordable Care Act or Obamacare or whatever you want to call it. The Affordable Care Act is essentially socialism to Republicans, and it's a healthcare panacea to Democrats. Neither of which, in my opinion, are actually true. But to be honest, it's a very complex thing. I certainly didn't understand Medicaid when I was first elected in 2010. And I've joked that I didn't even realize that dishes stood for the Department of State Health Services until about halfway through my first session in public health, which is pretty kind of representative of the legislature. So that kind of brings me to the body itself. Uh, I joke that when nothing gets done in the legislature, it's oftentimes better when a lot of things get done in the legislature. It's important to remember that the legislature only meets for 140 days every other year. And the legislature cannot vote on any non-gubernatorially declared emergency items the first 60 days. That's why you don't see a lot of action in the first 60 days. And so this means, though, that the members are under intense time pressure after those 60 days. They are trying to pass their own legislation. They're trying to analyze and review the bills that are coming before them in their particular committees, because they're going to have to vote on those bills. And so since they only serve 2-year terms, they only get one session to accomplish what they have been elected to and what they want to set out to accomplish. And that also means that most members are always running for reelection. So they've got the pressures of trying to pass legislation, but they're also thinking about their next election, which is literally, 30 days after session ends. And so as a result of those pressures, I tend to say that the legislature takes the path of least resistance. And by resistance, I mean whatever it takes to avoid constituent complaints. To me, this explains why we haven't really been able to, as a state, move forward in what I would consider pro-vaccine policies. It's not because the majority of Texans are anti-vaxxers or don't believe in the science of vaccines. It's because the individual members are really only hearing from their constituents who oppose vaccines. So it's a small but loud voice. And so it's easier when you're hearing from one faction to then acknowledge and deal with that faction. But it's also important to keep in mind that there are two chambers, the House and unfortunately the Senate. And I joke, we love the Senate. But tensions between the two chambers are often pretty common because both chambers are trying to move forward their own agenda. Earlier, we saw the Senate under the leadership of Lieutenant Governor Dan Patrick put out, I think, like 31 priorities. When I served, I remember he put out 10 priorities. And then you have the House, which is, a lot more members, so they have a lot more priorities that are a little bit different. But you oftentimes see some tension and competition between the chambers, and legislation, has to pass both chambers. And if members of the House they feel like a piece of legislation is like dead on arrival in the other chamber, they're really going to be less likely to vote for something that they view as controversial. And so, like I explained, Medicaid expansion really is viewed as controversial and as partisan. Now, of course, it shouldn't be that way, right? But my advice to everyone who wants to be an advocate on this issue is I understand the moral obligations and arguments for Medicaid expansion. And as faith leaders, I know you feel those, but really in the legislature, I think the best strategy is to make the issue less partisan and less controversial by focusing on the fiscal impacts and what happens to the state budget. So the Episcopal Health Foundation released a report in September of 2020. And it detailed the fiscal impacts to the state budget with Medicaid expansion. And according to this report, Episcopal Health Foundation argues that the cost to enroll about 1 million new people in Medicaid would be around $6.3 billion. But remember, we talked about the FMAP. So the state would not be on the hook for all $6.3 billion, but instead would be responsible for just 10% of that $6.3 billion, plus about $20 million for administrative. So Episcopal Health Foundation estimates that it would cost the state about $650 million to expand Medicaid. So the question you're likely to get is, well, how are we going to pay for it? How's the state going to come up with its share? And there are several different ideas. I think one idea that's the easiest to understand is by explaining that you can transition some people that are receiving various types of healthcare in this state that are funded 100% by GR or general revenue, no federal dollars. You can transition those people into this Medicaid expansion population. Because if they are eligible to receive some of these state services, they most certainly would be eligible to join the Medicaid expansion population. And some specific examples of that would include some women's health savings. Right now, the primary program we have in Texas for women's health is Healthy Texas Women's. And you could largely transition those women into the Medicaid program. The same would be true of the other kind of pots of money like family planning services and breast and cervical cancer screenings. And plus, women then would enjoy an entire array of benefits, including prenatal care, which is vitally important for health outcomes, healthy mommies, healthy babies. Additionally, you could transfer inpatient care of incarcerated prisoners. If you moved those folks into the Medicaid program, then the state would only be paying 10% of their health care, as opposed to 100% of the health care that we are paying as Texas taxpayers now. There's also some possibility of transitioning some folks that receive mental health care from the community mental health services. Some of those clients could be transferred into the Medicaid population. And then you have programs like substance abuse treatment, HIV medication assistance program, and the kidney health care program. All of those rely on state dollars, and those folks receiving those services could go into the Medicaid program. And again, Texas would then just be paying a fraction, 10% for the care that those people would receive. And there's also something that I don't really like to say out loud because we don't like to talk about taxes, but in Texas, all health insurers and HMOs must pay a 1.75% tax on gross premiums that they collect. So there's an estimated a little more than $100 million in credit that would go to help pay for the state share of Medicaid expansion. But again, I know we don't like to talk about taxes very often, but there is a portion of that that can be paid with taxes when these new policies through Medicaid are issued. And so those are just a few of the ways that the state could come up with its 10% share. And again, that's largely by not having to fund with state dollars specific programs where those eligible folks could go into the Medicaid program. So I really think the money is there. The legislature just has to find the will to do so. And that is obviously the hardest part. So looking at the different sessions and the different bills, I really would suggest that everybody look at the constitutional amendment path. I mentioned Representative Lyle Larson has a bill to put Medicaid expansion on the ballot. We've seen other red states successfully expand Medicaid that way. And so I think that that's probably where I would spend a lot of my time in discussions. It's really hard if you're a state representative to try and explain why you don't want to allow your constituents to have a voice on such an important matter. So I also think that offering this through a constitutional amendment kind of gives cover to Republican members. I'm not aware of any Democrats that are opposed to Medicaid expansion, so I'll say Republican members, but gives Republican members cover who are either opposed to Medicaid expansion or just reluctant to vote for Medicaid expansion. Again, it's that path of least resistance that I know that the bodies typically tend to take. And again, you really don't want to have to explain to constituents why you didn't want them to be able to vote. on something as important as Medicaid expansion. And so allowing a member to vote on a constitutional amendment sort of gives them cover. They can say, I may be opposed to it, but I certainly don't want to take my constituents' voice away from the debate. So, but again, this is, going to be either way. It would be a controversial issue, and so you really need to make sure you're focusing on both chambers, because again, there's been time and time again when I served where the House was considering doing certain things, but we knew that the Senate was never going to pass it, and so then we're asked, we're left asking ourselves, why do we want to cut up other members and cut up ourselves to advance a policy that's not going to ultimately pass in the Senate? And so those calculations do take place. So make sure that you're not just communicating with your state representatives, but also with your state senators. And I will say that, we're talking about politics, but it's important to remember, of course, we just had elections in 2020. And I know that there is a feeling amongst some groups and some advocacy organizations that this session may be the session we could get Medicaid expansion. But I want everyone to remember that although, yes, Joe Biden did defeat Donald Trump for the presidency, in Texas, the House actually became more conservative. So despite the millions of dollars that were flowing into Texas to flip the House, all they really managed to do was to lose one Democrat seat and flip one Republican seat, mine, which is arguably the most moderate Republican. So going into the 2020 session, it's my sense that Republicans feel very emboldened by that election and are not under any real fear of any kind of retribution at the ballot box in 2022. So this is why I think it's really important that we do our best to try and make this a nonpartisan or it can't be a partisan issue, because there's no real reason why Republicans are going to want to view what would be considered a Democrat priority. So that's why I say it's really, really important when you're talking about Medicaid expansion, stick to the budget, stick to the fiscal impacts. Because the reality is we may not get Medicaid expansion. We may not get it this session or next session. But that doesn't mean that there aren't some really great healthcare policies that y'all can be talking about and working on. And I want to specifically talk about women's health. There's a lot of attention that gets paid to maternal mortality and morbidity, and for good reason, because we have just some really horrible maternal mortality rates in this state. And it really kind of started back about in 2011 when the state decided to remove Planned Parenthood from the Women's Health Program. And the Women's Health Program at the time was one of those 90-10 match. It was a Medicaid waiver program that we received from the federal government. So again, we were only paying 10% and the federal government was funding 90%. So when we removed Planned Parenthood as a provider, the federal government said you're violating the terms of the waiver. And so they stopped sending those federal dollars. So then we had to recreate the safety net for women's health. And that safety net is now known as Healthy Texas Women. Certainly not as expansive as the services that were available prior to losing those federal dollars. And of course, the number of women served are limited to an appropriation, whereas under the old Women's Health Program, all eligible women could receive services. Now we are only able to serve the number of women that we appropriate for, which has been significantly fewer women than before. So keep in mind, as we mentioned, pregnant women roll off of Medicaid 60 days after they give birth. Now, for the last few sessions, we've been really focused on trying to extend postpartum care for women. I was actually able to get through some legislation a few sessions back that linked postpartum depression screening and treatment as a benefit to the Medicaid benefit to the child that lasted for a full year after giving birth, which allowed women at least to have that limited postpartum depression screening and treatment for a full year. But that's really not enough. We really think it would be best to allow a mom to stay in Medicaid for at least a full year. If we can't get full Medicaid expansion, then maybe we could at least allow moms to stay in Medicaid for a full year. And there's just been a host of studies that show how important that is. And the good news about that is the House actually passed this legislation last session, which was a huge win for women and children across the state. Now, unfortunately, the Senate never even considered the legislation. So I would say that in addition to your passionate support of Medicaid expansion, I would really urge you to work on this 12 months of postpartum Medicaid care for women. Because if we can't get the full Medicaid expansion, I think this would just serve so many women and children. And at the very least, I'm always giving people, I want to give options. I would urge that you seek out legislators who would be interested in studying, having the agency study and issue a report on the health outcomes and the costs and expenses related to women in Medicaid for a full year after they give birth. We know the outcomes in other states have been positive, but since we don't have it in Texas, we don't have any hard Texas data facts. But remember the FMAP bump I was talking to you about earlier. We got that 6.2% FMAP bump. Well, contingent upon taking those dollars, the state was prohibited from removing anyone that was on Medicaid as of March 18th of 2020. So in order to keep those funds, women got to stay on. So we are now literally approaching basically a de facto pilot program where women have been on Medicaid for almost a full year. And we know they have to stay in Medicaid in order to continue to receive that FMAP bump until the federal government determines the pandemic is over, which we don't know when that's going to be. So we're actually, I think, going to have a great cohort of women that if the legislature directs the agency to study the health outcomes and the costs and expenses, then we're kind of really able to sort of tee that issue up in the next session based on hard data that we would have in this state. I will say I've spoken to the agencies. They say there's usually about a 6-month time lag, which is why if you're not able to get the 12-month postpartum care in this session, you would have a whole interim to get that study done because we're not going to get that data immediately. But I think it's something that we should be working on, and it really is of no cost to the state because these women have been afforded the opportunity to stay in Medicaid because of the FMAP bump. So, I would say that change is slow and oftentimes comes very, very incrementally in government. But I would encourage everyone not to, give up or get too discouraged. And, what we say in the legislature is don't let perfect be the enemy of good. And I know when I was served, a lot of times that was, a hard lesson for me to remember. But that is the lesson. And as advocates, we just have to be patient and stay, focused and always look for, other opportunities that we can make a difference, even if we can't get what our main goal is.